A lot of people are like, oh, I'm old. It's too late. I already have plaque in my arteries. I'm not doing anything about it. I had a 93-year-old woman. So sweet. I'm like, why is she coming into my one-on-one and my group program? She reversed her AFib. She improved all of her lab values at the age of 93.
Our next guest, Michelle Routhenstein, is just the expert to help us navigate the world of preventative cardiovascular health. Michelle has her master's in clinical nutrition. Michelle is the founder of Entirely Nourished, a nutrition counseling practice dedicated to optimizing heart health. Michelle is a member of the Forbes Health Advisory Board.
Cardiovascular disease is the #1 cause of death globally, but 80 to 90% is preventable. Now, tell me how that makes sense. I worked with heart failure specialists, preventative lipidologists, cardiologists. I kind of made my own fellowship in cardiology with these top Manhattan-based cardiology doctors. I realized that
Hi, my name is Chris Burris. I'm a longevity expert and the chief scientist at a lab focused on a longevity molecule. My primary focus is to help people live longer and better lives with science. Make sure to subscribe and share so you and your friends can live longer and better. Well, actually, so you and your friends can live beyond the norms.
Hi, and welcome to the next Live Beyond the Norms Health and Longevity podcast. Cardiovascular disease is one of the greatest obstacles to achieving a long and healthy life. If you want to live beyond the norms, you need to understand your risk of cardiovascular disease and, more importantly, understand how you can reduce or eliminate that risk. Our next guest, Michelle Routhenstein, is just the expert to help us navigate the world of preventative cardiovascular health. Michelle has her master's in clinical nutrition. She has many letters behind her name, RD, CDE, CDN. She is the author of the book, The Truly Easy Heart Healthy Cookbook, Fuss-Free, Flavorful, Low-Sodium Meals. With over 13 years of experience, Michelle is the founder of Entirely Nourished, a nutrition counseling practice dedicated to optimizing heart health. Michelle is a member of the Forbes Health Advisory Board and the National Menopause Foundation. She is here to help us understand how to reduce our heart disease risk. Michelle, thank you so much for joining us today.
Thank you for having me. I'm excited to chat with you.
So before we jump into your area of expertise, I like to go a little farther back. Actually, I like to go a lot farther back. What was it like growing up, little Michelle? Where did you grow up? What were your parents like? If there was some event or someone you could pinpoint as the reason you would ultimately pursue a master's degree, become an author, help people avoid or manage cardiovascular disease, what or who would that be?
So many questions that you may take a while, but I'll try to be very concise. So I was born in New Jersey in Bergen County. I've always wanted to be a physician, a doctor. And, a big part of growing up, my dad's favorite saying was, without your health, you have nothing. And that really stuck with me. So when I went to NYU and had to decide between clinical nutrition and becoming a dietitian or being a physician, I naturally fell into clinical nutrition because of the preventative approach. When I was shadowing physicians, it was all about, let's treat this, let's treat that. Here's a medication, here's a medication. And growing up, it was all about what naturally we can eat, what we can do in our lifestyle, being physically active. And all of those components really allowed me to pursue the preventative approach, which is really science-based nutrition and optimizing your cardiometabolic well-being and giving you energy, vitality, and allowing for functional aging, increasing our health span, so to speak, is really the main focus because, again, without your health, you have nothing.
Yeah. I think, well, first, that was nice and consolidated. That was awesome. I think, yeah, without your health, you do have nothing. It's interesting. So I interview a lot of people, and some of the fun people I like interviewing are people who've gone through the classic, got their MD and now are kind of folding back and going, well, maybe we should do some more preventative stuff. And you, so as you're kind of deciding what path you're going to go on, had enough experience with physicians to go like, they're not looking for the root cause. Can you talk a little bit more about that? Because I think that's very different, right? I think everybody's unique, but that's a very unique kind of aspect of the decision you made early on.
Well, so what really was probably that last thing that kind of was like, this is what I'm doing is I was in the hospital and I was actually shadowing an ICU dietitian. And this 35-year-old male was getting his legs amputated, and he had diabetes. And I went and just had a conversation with him, and I said, tell me a little bit about your story. And we just started talking, and he was like, I took all my medicines, the doctor told me to take all these medications. I'm like, oh, but did you ever see a dietitian? Have you ever spoke about diet and the whole realm of diabetes? And he looks at me, he's like, no, they told me to just take my medicine. They didn't mention anything about nutrition. And that stuck a chord at me, because it's like diet, like what you eat is going to help your body metabolize glucose and prevent these complications. And the fact that I'm talking to him at the stage of an amputation, which is going to change the young person's life forever, that really was like, we're missing the point. We're missing the time of opportunity to really help prevent this conversation from even happening, to prevent people from coming into the hospital, from getting sick. And so my perspective was really about, there's a prevention piece, and that really means targeted nutrition and really helping people understand how what we eat, how it affects our cardiometabolic well-being, from our glucose to our cholesterol to our blood pressure to our vascular health to our energy. There's so many components that are often not touched upon when we talk about health.
Wow, yeah, that's a pretty impactful story, right? Like we're way too late, and haven't had those kind of basic conversations. So when you get a master's in nutrition, do you have like a focus at that point? Like, 'cause I don't know how that course of study goes, and what was your focus if you did?
Yeah, so I actually did my clinical residency, which is similar to a physician's residency, but with nutrition at NYU. And I did a dual program where I was in the NYU master's program and I did my internship at the same time. And NYU's program, at least the time that I was there many years ago, was focused on clinical nutrition. So really focusing on medical nutrition therapy. So how do we help prevent people from getting into these disease states? But then once they're in, how do we prevent complications from occurring? So it's really focused on nutrient adequacy, vitamins and minerals, biochemistry, really focusing on the biological mechanisms that take place in your body in relation to nutrition. So it's really comprehensive in the realm of clinical nutrition. But in these master's programs, there's a lot. You're kind of a generalist when you leave, because it's not like we only look at cardiovascular disease. I look at gut health and Crohn's disease and irritable bowel syndrome and Hashimoto's, everything. So every single disease state. And so you know a little bit about everything. And then only until after I got my RD, after I got my master's, I was like, there's something missing here. Cardiovascular disease is the #1 cause of death globally, but 80 to 90% is preventable. Now, tell me how that makes sense. Right? Because if we want to live long, healthy lives, we want to prevent this. So, I went on this mission of asking doctors, why is this? And many people were like, oh, patients are non-compliant. And I'm like, patients don't want to be non-compliant. That's the worst answer you could possibly give me. And I realized as I worked with heart failure specialists, preventative lipidologists, cardiologists, I kind of made my own fellowship in cardiology with these top Manhattan-based cardiology doctors. I realized that people don't know they're at risk. And they don't think that heart disease would happen to them because they may not be overweight or obese. They're not educated on what the risk factors are. And actually, there's multiple risk factors of heart disease, right? If I asked you, heart disease, what do you think of first? You'll probably say cholesterol. Maybe you'll say blood pressure. Maybe. But you're not looking at inflammation. You may not be looking at gut health. You may not be looking at osteoporosis and menopause. And you might not be looking at the vascular space. And you might be like, endothelial function. What the heck does that even mean? But that's the earliest sign of heart disease. And so a lot of times, what ends up happening actually is heart disease brews in your arteries decades before it actually pops up on a calcium score test or on any other of those more advanced testing. And we have this opportunity to really take early action to prevent heart disease, but most people don't feel it. They don't know that they're at risk. And so it's brewing silently until they have an event or they have further testing showing plaque formation in their arteries.
It's interesting that you brought up, physicians saying that they're non-compliant because I go two places. One, literally to a conversation that I had last night with somebody. I can't remember what. I think they were just struggling with health in general. They were a little overweight, and most of my conversation was about you've got to get that right. Like you've got to move every day. You've got to prioritize yourself over other people. And it was just clear she wasn't in the place where she's gonna actually prioritize herself and get some sort of movement every day, right? So that was where I first go. But you're actually talking about these physicians probably haven't even advised them well on nutrition, right? And you think about clinical nutrition and you're really trying to do preventative, that happens. I know in where you are today, you get to deliver a lot more value before they're actually in the hospital, right? I think at that point you're like, how do we get here? That's just an interesting story. And so how does, as your practice has evolved, how does kind of non-compliance is probably the wrong thing. It's like mindset. It's limiting beliefs. Like how does that fit into how you kind of treat and manage people?
I think the biggest part is people don't understand it. Heart disease is complex and nuanced. Like think about even just plaque progression, which is the number one leader of heart attacks and strokes, etc. People don't understand what's going on. So if you don't explain the why, they're not going to actually follow through. So my practice really focuses on, let me explain what's going on in your arteries. You need to know. I don't care if you don't have a science degree, don't want to know anything. I need to tell you. And I might show you in a picture of how plaque gets formed, because then you're going to say, okay, I understand now. My acid reflux, that inflammation is related to that plaque formation process. Oh yeah, I've been constipated my whole life. I never thought it was a big deal. Well, if you don't have good bowel movements, how can we excrete dietary cholesterol? It's one of the biggest detoxifying systems that naturally happen in your body. You have to understand these things because then you're more aware of signs. Oh, I thought I was getting older, so I'm tired more. No. Maybe you're not having enough of certain micronutrients that your body needs. So I'm very big about connecting the dots and explaining the why, but then putting that into perspective of your mindfulness of how you feel. How is your blood pressure reading you can take at home? What is your labs doing? So when we have metrics, we have how you feel, and we have the understanding of, well, why, how does this all connect? You are not only going to actually follow through, but you're going to follow through for the long haul, which is the most important aspect of heart disease. It's a progressive disease. What you do for 1 month, not really going to make a big difference. What you do for the rest of your life, day in and day out, is important. And I think a big part of it is also we live in a very I want a quick fix. Take this supplement, take this, take that. There's no such thing for that for heart health. It is something we need to make into habits, and we don't need to do all of it at once. We need to prioritize the top 2 or 3 things. We need to continuously add, but I really emphasize mindfulness. How do you feel? You just did these little tweaks. How did that change anything of what you feel, your bowel movements, your sleep, your symptoms of, let's say, menopause? All of those things are definitely something you can attribute to your efforts. And when you see, wow, this is working, I feel better, and now my labs show that they're better, and all these things are there, you're more apt to actually follow through and continue that because you're seeing it, you're feeling it, and you understand why it's important. You understand what's going on beneath the surface that you don't know because, you're not seeing underneath in the arteries.
Yeah. I like your approach, and I actually have a question kind of further down the road. You already answered my next 2 questions, which are, where does cardiovascular disease rank? Although you might actually have statistics on what number of people are passing or being diagnosed with cardiovascular disease, and then 80 to 90% of it is preventable. That's amazing.
Yeah.
Yeah. So how much does genetics play a role in cardiovascular disease?
It's a great question. Genetics, there are many parts of genetics that can light up and accelerate plaque progression, but the environment has to be conducive to that. So I'll give you an example. There is a specific lab called LP little a, lipoprotein little a. And if it's above 75 nanomoles per liter, there is an increased risk of atherosclerosis, aortic valve stenosis, heart failure. There's a lot of increased risk. When we look at outcomes data trials, there's no supplement, no drug that will actually lower the risk of major adverse cardiovascular events when we target LP little a alone. this genetic form that we can't really change right now. However, when we look at studies, we see that if we can optimize LDL, ApoB, blood pressure, glycemic control, insulin resistance, waist circumference, weight management, inflammation, all of these markers, we can help reduce the risk of this genetic marker from causing any harm significantly, almost to the extent where it would be put on the same level as someone who had no genetic risk factors, but they had all of these elevations. And so it's important that we realize that while genetics plays a role, it accelerates plaque to form at lower thresholds of these cardiometabolic metrics. So we have to be stricter. It does not mean that heart disease is inevitable for you. I think it's a really important thing. Many people will be like, oh, I have bad genes. That's what it is. I'll eat what I want. Well, now you're adding fuel to the fire, and it's going to accelerate at a much earlier state in your body. So your targets, if you have a family history or you have high Lp(a), your targets are much lower than the general population. And it starts brewing as early as when you're kind of, born. So important that we're being as early, we take as proactive action as possible. And I see this also because I am a mom of 4 boys, and I really believe in the fact that we need to be teaching our children. You want to eradicate heart disease? I want you to eradicate heart disease in your family. And how do we do that? We start with our kids. We bring them in the kitchen. We teach them how to eat. My kids eat exactly what I eat, and I eat exactly what I tell my clients to eat, because it's important that we look at that component. If we teach our kids that there's no such thing as a children's menu at a restaurant and we're eating, a well-balanced diet, it's going to help them build those habits and help reduce plaque formation in early life too.
Yeah, I know with my kids, by the way, 4 boys, bless you. I have 1, and that's enough. I have 1 boy, 1 girl, they're twins. So good, I'm done, but that's impressive. Yeah, it's amazing with kids what you like when you just establish what the baseline is, like it just is what it is. And right, like you don't order off the kids menu. I've never really done that. And really should have done that. Like that's good. They're pretty good eaters now, and they're focused. I had my son watch one of my interviews about ADHD, and he's like going gluten free, but also kind of has pizza, right? So then we got to figure like that's not the right choice. So it's really fun to carry them along on the journey. So when do we say that somebody has been diagnosed with cardiovascular disease? Like what is that point, and what are we looking for?
So there's a lot of different types of heart disease. And so if you're talking specifically about coronary artery disease, a lot of times we look at it when we're looking at like a calcium heart scan, and we see calcified hardened plaque in the arteries. Even if they don't have any symptoms, we call it subclinical atherosclerosis, and that's one of the diagnoses. But there's also heart failure. There's also cardiomyopathies. There's so many different types of heart disease, atrial fibrillation, that need to have recognition, because our heart does a lot of different things, right? We have a plumbing system that we want to optimize. We have a pump. We needed to pump that oxygenated blood throughout our whole body. And then we also have the electrical system. And we want to make sure that we have good sinus rhythm. We have good heart pump, so that we're not struggling. Your heart's not getting enlarged or struggling to pump oxygenated blood throughout the body. And we don't want it to be clogged, because if it's clogged, it's going to cause the heart to enlarge. It can lead to more heart attacks. It causes more strain in the cardiovascular system, leading to increased risk of both stroke and heart attacks.
So I like to ask, and one of your goals for coming on was for listeners, they should know their numbers and optimize them to the target. So what are the numbers they should know, and how do we know what the target is, and then how do we get to that target?
Yeah, so great question. I'll try to cover the big ones. There's a lot of littler ones that I'll probably not, just so that people have a big picture of things. So let's start with inflammation. So the most common lab that you can ask for that has a good indication of inflammation relative to heart disease is called HS-CRP, high sensitivity C-reactive protein. And we want that to be less than 1 milligram per deciliter. Okay, super important that that we are targeting our HS-CRP, because if there's inflammation, it accelerates both aspects of atherosclerosis, so that plaque formation. It puts burden on the heart muscle, leading to potential heart failure, and it also can cause atrial fibrillation, the arrhythmia that can increase the risk of strokes and blood clots. So super important that we're targeting inflammation. If you don't have this lab handy, you can also, another way to look at it in the interim until you get this lab is check your waist circumference. So a lot of people will think, oh, it's my pant size. It is higher than your pant size. We're talking about your belly button. That's where all that visceral fat is that's more cardiometabolically active. And that can lead to more pro-inflammatory cytokines, these proteins that lead to metabolic dysfunction. Super important that we're checking for inflammation. But it can happen from acid reflux, bloating, psoriasis, joint pain, osteoarthritis. There's so many signs. Hashimoto's thyroiditis. There's so many different ways that inflammation can appear in your body. So we need to find the cause. What's causing the inflammation? Most of the inflammation is usually in your gut. So we need to understand kind of what foods you're eating. This is actually one of my favorite parts of research in terms of, it's called nutribolomics. So looking at what you eat and what metabolites are actually created by your gut when you eat them, which can either increase cardiovascular disease risk or decrease it. So really looking at that aspect is important too. So when we have inflammation, we have to understand why. What's causing the inflammation? If it's acid reflux, it's usually a motility issue. Most people think, oh, you make too much acid. No, the acid reflux is the fact that you're not having a complete bowel movement, so things are going the opposite direction. So we need to fix your motility. If it's psoriasis, we need to assess kind of the triggers, but also focus on what we're adding to the diet. I think a lot of people define their diet by removal of foods versus getting foods in adequate nutrients. A lot of times people are like, yeah, I eat my fruits and my vegetables, or I'll eat this and eat that. But their targets, their volume, the types of fruits and vegetables are not where we need them to be to actually move the needle when it comes to an anti-inflammatory diet. So that's one aspect. The second one I'm going to bring up is blood pressure, because blood pressure is so important. If I can make somebody today on your podcast go take their blood pressure on a regular basis, I have met my goal. Why? Because blood pressure can lead to high blood pressure. First off, you don't feel it, but it can lead to strokes. It can lead to dementia. It can lead to erectile dysfunction. It can cause plaque. It's actually one of the first things that make plaque form in the arteries, because it can cause that micro tear. That endothelial lining can tear and cause more of that ApoB to go in and lead to that plaque formation start. So super important that we're targeting blood pressure to less than 120/80 on a routine basis. So know your blood pressure. And if you know your baseline is, let's say, 90/60, and then all of a sudden it's like 110/70, that's not your baseline. Know where your baseline lies, because that means your heart is working harder than it used to, and we need to figure out why. Blood pressure is one of my favorite topics because it responds so well to diet. There are many mechanisms for why blood pressure rises. Some of them include insulin resistance. Some include a negative ratio of sodium to potassium. Some of it is low nitric oxide bioavailability. There's so many reasons. And when we find out why and we address that through diet, it is one of the first medications that get off of my clients' list, because we don't want low blood pressure. So when we see, oh, wow, it responded really well, we figured out the target and we keep it normal, the physician's like, well, we got to remove that medication because low blood pressure is dangerous too. So super helpful, and it's easy to monitor at home, track it, and see how it's responding to diet and make those adjustments as necessary. So no blood pressure. So inflammation, blood pressure. Let's talk a little bit about insulin resistance. So insulin resistance is kind of a decade before hemoglobin A1C and blood sugars elevate. Your body struggles to utilize insulin. So if your pancreas is pumping out insulin, but your cells aren't opening up that cell and letting glucose in, it causes insulin. It doesn't allow insulin to do its job. So what happens is you now have a lot of insulin in your bloodstream. And so glucose is down because insulin is opening up the cells. So your blood sugar won't elevate in that 10-year time span, but now you have a lot of insulin. And when you have a lot of insulin in your bloodstream, it causes more free fatty acid breakdown. It leads to more oxidative stress, inflammation, and more potential for dyslipidemia and high triglycerides to occur, which can increase the risk of blood clotting. So super important that we address this. And a lot of times, people will say, okay, how do I address this? Let me just remove all the carbs. Well, if you remove all of the carbs, you actually increase your risk of AFib and cardiovascular disease. You're kind of taking the problem and removing it out versus teaching your body how to become insulin sensitive. So we need carbs. It's our primary fuel for our brain, but we need it paired with adequate amounts of protein and adequate amounts of fiber and healthy fat to help with utilizing it better. One way you can test for insulin resistance is LPIR or HOMA-IR. Those are great parameters to assess where you are, and we want that less than 25. So that's the other thing. If your blood sugars are high, you have high hemoglobin A1C, we definitely want to address that too, but I think we don't talk enough about insulin resistance and also the blood sugar relationship too. So important that we're looking both at hemoglobin A1C, targeting that to be less than 5.5, and targeting our LPIR to be less than 25. And then any questions?
No, good. This is good. I have comments, but you're on a roll.
And then cholesterol. So when we talk about cholesterol, we have to understand that there is atherogenic cholesterol and non-atherogenic cholesterol, meaning cholesterol that makes plaque in the arteries versus doesn't. We see a linear relationship, meaning the higher your LDL, the higher the risk of cardiovascular disease and the higher the risk of plaque progression. Mm-hmm. Okay. A more specific atherogenic type of cholesterol is something called ApoB. And this is a protein that sits on top of the LDL that goes into the arterial wall and makes plaque. Most people, their LDL and ApoB correlate in terms of, being in the same zone and being the same kind of, okay, that's high, we need to address it. But there are a small part of the population, what we call discordance, which means they may have normal looking LDL, but their ApoB is super high. And so in those people, we want, that's why we like to test for ApoB, because if your ApoB is very high, but you didn't know that or catch that from an LDL, just an LDL alone, then we might be missing you in the risk profile. Okay. There are a lot of NMR profiles where you can look at the amount of LDL particles and you can assess how many small and dense ones you have or how many large ones you have. Ideally, we want low LDL particles and we want low, small, dense particles because that's what is more atherogenic. It causes it to surpass into the arterial wall and cause more plaque to form. With all of that said, these targets are based on your risk. So in the general population, you have no genetic predisposition, your Lp(a) is normal, LDL should be less than 100 milligrams per deciliter. If you have a genetic family history, or you have other risk factors, or you have known plaque in your arteries, we actually want that less than 70 milligrams per deciliter of LDL. Your ApoB kind of has that same risk factor target based off of where your risk stands. And that's why we need to kind of personalize the risk assessment to ensure we're reaching those lower targets based on your relative risk. If you don't have an ApoB and you're going to ask for it at your next doctor's appointment, which I highly recommend you do, you can actually calculate a surrogate marker for ApoB cholesterol, and that's called your non-HDL cholesterol levels. So you take a standard lipid profile, you take your total, you subtract it by your HDL, and that gives us a number called non-HDL cholesterol. And we want that to be really less than 100 milligrams per deciliter in the general population, and we want it even lower in those who are very high risk, so less than 85 milligrams per deciliter. So all of those things we really want to hone into to make sure we understand it well, and we're also making sure that we keep it low as quickly as possible. I like to kind of I think there's a lot of things on the internet being like LDL and ApoB don't matter, blah, 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 blah. And I really just want to emphasize this for your audience. There was actually a recent study that looked at individuals who were on the ketogenic diet. They were lean, they had a healthy body weight, they had no high blood pressure, they didn't have any metabolic dysfunction, no high insulin resistance. And their LDL and ApoB were very high because they were on a ketogenic diet, which increases those values. And they looked at plaque progression, soft plaque, which is more dangerous than hardened plaque, in in one of those clearly scans. And what they found was that these individuals had the most rapid plaque progression than any other study ever seen. So LDL and ApoB cannot be high, even just in that 1 year time frame. That can cause a lot more higher risk of heart attacks and strokes in younger populations. And so LDL and ApoB need to be part of the conversation because we need that to actually make plaque. There's a lot of other things, like I mentioned, that are important for vascular health, avoiding the environment that accelerates plaque. But without ApoB and LDL, we cannot make plaque to begin with. So we want to lower it, and we also want to make sure we're protecting the vascular space to stabilize current plaque, shrink soft plaque, and keep the environment healthy to reduce your risk of cardiovascular disease and its complications.
That's awesome.
Hey, super quick break from the podcast. Hopefully you're loving it. This is a way you can support the podcast and take advantage of a great offer. We're offering 50% off of one of our MCT bottles. MCT is an amazing oil. Add the ESS60 molecule to it. It's even more amazing. All you got to do is leave a review on iTunes. Send us a notification that you've left that review. We'll get you a coupon code. That'll get you 50% off of our MCT oil and free shipping. Back to the podcast.
Right. So we've got inflammation, HS-CRP. By the way, we're doing an ad hoc study on HS-CRP for my product because we had a doctor tell us that our product in 4 to 8 weeks we'll drop it within normal range. So we're actually doing an ad hoc study. We can talk about that later. That's kind of very cool. I had never thought about, and maybe we need a little pressure cup on these Oura rings, right? So that we can get a blood pressure, right? I don't even know if that's feasible, but to have it on a regular basis, right? Because the trends matter. They actually matter. And so if you're trending up, like you gave the one example of your kind of normal and then pop up to a 110 or whatever, like let's try and figure that out. Insulin resistance. Now, you said if you just cut out carbs, there was some benefit, but you're not feeding your brain. Could you kind of go over that again?
Yeah. So if you take out carbs, you're essentially telling your body, like, you don't learn how to process these. I'm just getting rid of what causes what you need for insulin. But your brain needs 130 grams of glucose every single day to operate. It's the primary fuel. So what does it do? Whatever you feed it, it's going to work really hard to make glucose, to make carbs,
Yeah.
right?
Yeah.
So now what happens? You're putting your body in survival mode. It also, if you cut out all carbs and you go on a keto diet long term, you become nutrient deficient, you become constipated, you're not feeding your gut microbiome. There's so many other elements to it. So you're putting a Band-Aid on the solution versus actually addressing the situation. We don't want to eliminate carbs. We want to be eating them in their appropriate pairings to allow for your body to break down the glucose, put it into the cell where it belongs, and excrete what it doesn't.
And okay, so we've got that from an insulin resistance perspective. Next is cholesterol. I may fall into, because I'm literally in the middle of a little journey right now where my LDL and cholesterol high. I significantly increased my protein consumption so I could add muscle mass. I'm about to turn 56. Normally, we don't add muscle mass at this age, but you can. So now I got to figure out how to also do that in a heart healthy way, I think is the concern, because I have high LDL, high cholesterol. The day I got those results, I happened to see a presentation from a guy, and I'd like your feedback on this. His name is Dr. Christopher Davis. And he basically said the basic lipid test isn't kind of useless, isn't kind of useful. It's absolutely useless. You need to get your advanced lipid profile to really dig in. And you kind of did some workarounds like how you might be able to use the basic. How do you feel about that kind of sentiment? How valuable versus invaluable basic versus advanced LDL profiles are?
They usually go in tandem. So a
Yeah.
lot of times people get an MMR profile, an advanced profile. They had like their whole history of their normal one, and the LDL is high. The LDL particles are really high. The small and dense are really high. It's all correlated. And when I target treatment to lower them for all of my clients, all of them go into normal range. That's the target. So I think to say it's useless makes it seem like LDL and ApoB don't matter. And we have so much actual evidence that shows they do matter. So I think it can really make people, throw up their hands and be like, I'm going to continue what I'm doing. I'm fine, until you realize, oh, wow, there's a lot of plaque in my arteries now. And I should have been more aware of it. Some people say, I wish I was more aware of how my cholesterol panel was so important to me 10 years ago. I
Yeah.
ignored it. And then I found this high calcium score. And now I'm like, I should have done something, and I can't go back. And so I want to hopefully influence everyone who sees it. Like, all of these numbers should be normal. When we talk about a heart healthy diet, I am not looking at just LDL and ApoB. I'm making sure you're not becoming insulin resistant. We're also targeting blood pressure. We're also targeting inflammation. They all work in the same way because you're feeding your body what it needs.
Yeah. Yeah, I think to be fair, maybe what he was saying was in particular instances, it's not useful because, as you were talking about the ApoB, like if you have that in the right space, then your LDL from your basic maybe doesn't matter as much. Anyway, so I'm on this journey. I'm getting a clearly scan on Wednesday. My calcium was a little high, and I gave him the data, and he's like, I was trying to avoid clearly because it's out of pocket and not inexpensive, as you know.
Yeah.
And he was like, no, you probably need to get it. So anyway, it's kind of interesting to be on this journey where I can tell you, I really would like to not change my diet because I am putting on muscle and that feels really good. But I have this data, like this is where what really matters is the data. So I've got to figure out a way to kind of, I think, drop dramatically my animal protein, but still get lots of protein. So I don't know if you have any advice there while I have your ear.
So it depends on how much you're eating, but we actually see a lot of diets when we have a very high amount of protein, particularly leucine. It can cause more vascular inflammation that leads to more plaque progression. So there needs to be a balance there. It doesn't mean that we're having a low protein diet or causing muscle loss. We want to make sure that when you're thinking about gaining muscle, you're doing it in a way that is not harmful in other ways. So really doing it where you're meeting your protein needs, but you're not exceeding it, because the high amounts of those branched chain amino acids, the high amounts of leucine, that's when we get into trouble. So when I say nutrient adequacy, which is a big part of my practice, I'm talking about not too little, but not too much. There's an adequate amount for you based off your height, your weight, your activity levels, your goals to make sure both of those happen. And when we talk about longevity, of course, we want good amount of muscle mass and protein adequacy. But I've been seeing so much recently of like people overdoing it and not realizing the potential harm that may cause in the interim.
Yeah, that's, I think, I might be one of those, and I'm currently working to address it. I saw on one interview, and you actually mentioned it today, that was discussing just briefly erectile dysfunction and how it can be a sign of cardiovascular disease. Can you talk a little bit about that? How serious of an issue can erectile dysfunction be as it relates to cardiovascular disease?
It's actually one of the earliest signs of cardiovascular disease. So the arteries that are going to the private parts, it's getting clogged. So a lot of times there's a correlation between erectile dysfunction and plaque formation in the arteries. When you go get a calcium score, for instance, we look at your coronary arteries. So in men, a lot of times the bigger arteries are what gets clogged. In women, it's actually the smaller arteries that tend to get clogged more quickly. And so when we're looking at but you have arteries everywhere. So when we see that there's plaque formation in the coronary arteries, this gives us a red flag. You probably have plaque formation in other parts of your body too. And so we need to make sure that we are aware of that's an early sign. A lot of people are like, yeah, I'm getting older. Of course I have ED. But it's like, no, it's not something that should just happen. And it's an early warning sign that if we actually take more of a aggressive approach to assess your cardiovascular risk, we can actually help you prevent cardiovascular issues in the interim. So there are many ways of signs, but we need to be very aware of, hey, I need to check this out further. I need to do something more proactively and not wait until something happens to then react.
Yeah, I think there are so many things in our mindset is changing, and I'm happy to kind of be involved in, with this podcast and changing the mindset about, hey, like what happens as you age? It's like, I remember at one point my mom was like, why are you working out? Right. And I'm like, because I want to feel good and look better. And I actually haven't had a 6-point pack at any point, and I will get there. And it's just a very generationally different mindset. And now we're like, yeah, erectile dysfunction isn't something that just happens when you get old. Like, it doesn't have to happen at all. Like, if you look at the literature, I interviewed this guy, Dr. Paul Nash, who's a gerontologist. And my favorite phrase from him was, everything is age appropriate. Anyway, I just think that's an excellent attitude as we age. You also talked about bowel movement quality, and you actually said it was mind-boggling to you that doctors don't talk about bowel movements more. Like, what are we looking for? You talked about it as the way that we excrete cholesterol. So if we're like, maybe I have like high cholesterol and now I need to start getting rid of it, it's going to come out in bowel movements. Talk about where the ideal position is.
Yeah, so I love to refer to something called the Bristol stool chart. It's actually one of the conversations I have the first day I meet with my one-on-one clients. Like, hi, nice to meet you. Now, how do your bowel movements look? And I
I want you to picture your stool and then describe it to me.
It's funny though, because everyone's like, yeah, I'm regular. And I'm like, okay. And then later on, after 2-3 weeks, they go, Michelle, I had no idea what regular meant. And they're like, I'm having magical poops. And I'm like, yes, I want you to put a marker on your calendar, and we're checking your cholesterol in a month, 2-3 months, and seeing where it goes. That's a sign to me we're actually getting rid of some of the cholesterol metabolism in terms of our absorption, our recycling, all these things. There's different modalities in which we are looking to lower cholesterol, but bowel movement is a big part of it. So a lot of times if people are constipated, that's a sign to me, hey, that's one of the biggest things we need to work on from a gut health perspective, but also from a cholesterol excretion position too. So the Bristol stool chart is a stool chart. It gives you 1 to 7 of different types of bowel movements. And the first 2 are more of a constipated viewpoint. The third one is you lack insoluble fiber. The fourth one is optimal. We want a little bit more of more volume, but type 4 is what we aim for on a regular daily basis. Type 5, we're lacking maybe some soluble. It's a little bit more, it's not as well formed. Type 6 and 7, there's more diarrhea, there's more malabsorption. Something's bothering your gut, and we need to understand what that is, because you're getting rid of a lot of electrolytes and micronutrients through that process, and it's not good for inflammation, heart health, etc. So, and you're not binding cholesterol. You need to have that effective amount where you're actually binding the cholesterol effectively. So I like to look at Bristol stool chart. It tells me a lot of information, but also it helps people stay on track, right? Remember, I told you, you don't feel high cholesterol, but if you are like, wow, I have these magical poops, or they're great, and then all of a sudden you go back to a 1 or back to a 7, that's a warning sign of, ooh, I need to adjust my diet. I need to get back to where I was. So I like to put in a lot with my clients. Like, I want you, when you feel amazing, I want you to take a second. Like, capture that moment in your life. And I want you to always feel like that. So when you don't feel like that, what's missing? What did we change? What didn't we do that we did before? Because when you become mindful of these changes and how it impacts you, then you want to continue doing them. And when you go off track, you're like, oh, I feel so tired today. Oh, I ate this yesterday. Oh, I didn't work out. Like, you can connect the dots, and that keeps you like, okay, I'm going to get back on track today or tomorrow.
Do you ever look at, so talking about kind of gut health, do you look at food sensitivities? Is that something that you investigate, maybe in a case where inflammation you're struggling to kind of get inflammation under control, or how do you feel about that?
I do it more on symptom management versus a sensitivity panel. A lot of them are inaccurate, and it causes a lot of restrictive eating, and it's not sustainable. And if I told you how many times people have come, I'm not usually the first stop of a dietitian when someone comes to see me. I'm usually the last stop, and they've been to like functional medicine doctors that told them to remove all of these foods from their diet. And now they're like, I don't know what to eat, so I'm just eating this, which is like something you shouldn't be eating, but they just put up their hands. they stop enjoying food. My approach is not restrictive. My approach is let's make sure we're adding in the foods that you like, but in the right proportions, in the right amounts that gives us therapeutic effects for all of these metrics, for vascular health, for longevity, to ensure you're building good muscle mass, you're helping with gut health, you're doing all of these things, and you're nourishing your entire body so that it can thrive. So my approach is not, oh, get rid of this and get rid of this and get rid of that. That's the reason why you're inflamed. Most times it's what you're not eating enough of that's causing the inflammation. So my perspective is different. I mean, if someone comes to me and they go, hey, Michelle, I'm celiac or I have a gluten insensitivity, well, obviously I'm not going to give you gluten. And then my biggest thing is, well, are you getting the nutrients that are found in gluten from other foods? Right? A lot of times people remove and then they don't realize, okay, you took out dairy, but now do you have enough calcium? Because if you don't, we're taking it from your bones. And guess what? Your risk of osteoporosis goes up, but your risk of vascular calcification goes up. That calcium from your bones doesn't just like come into your arteries and do what it needs to do. If the environment is conducive, there you go. You got some more calcium deposition in your vascular space. And so nutrient adequacy has so many different meanings and roles, but important that when we're avoiding something, what are we adding in to help make sure you're getting that nutrient that your body really needs?
Are there any foods that you are fairly consistently, or like everybody's in of one, but fairly consistently putting into people's diet and also fairly consistently pulling out or reducing in people's diets?
I mean, as a whole, like as a topic in general, right? I mean, we're
Yeah.
trying to reduce a lot of saturated fat, a lot of sodium, a lot of refined sugar, trans fats, the way we prepare food that's fried, processed, all of that. But a lot of times people who come to see me, for the most part, have some idea of that, except for the saturated fat component. They're like, Michelle, I don't eat processed foods. I eat healthy. And their definition of healthy is just like clean eating. The issue with clean eating is when it comes to heart disease, it's not necessarily nutrient specific. So if we have a very high saturated fat diet and the allotment will be dependent on you specifically, your labs, your age, your gender, all these things, that if you have excess of that, it can block the LDL receptors on your liver from actually breaking down LDL. More goes into your bloodstream. And then the foods we need to add in are a variety of things. A lot of times people don't have enough nitric oxide converting vegetables. They don't have enough glutathione converting vegetables. They are not eating fruit because they think the fruit is what's causing their insulin resistance. Hint, it's not. They're not.
Spoiler alert.
A lot of people are scared of eating whole grains. Oh no, I can't eat any whole grains, because it's a carb. I think we're in this very like low carb error, and that's causing a lot of fiber deficiencies, nutrient deficiencies, vitamin C deficiencies, folate, potassium, magnesium, manganese. I can go on and on and on. You can't get that if you're not eating that volume in your food. I'd also say omega-3 is both in the EPA, DHA, alpha linoleic category is deficient in many people. I would say a lot of butyrate converting foods like soluble fiber is low in many people. There's a lot of things, but again, it's personalized, because if it's not, you put your hands up and go, this is too complicated, I'm out. And so a big part of it is meeting people where they are and making sure that it works within their diet. And people come to me and say, what, are you going to make me vegan? And I'm like, no, if you want to be vegan, sure, you can be vegan. And I'm just going to make sure that you're getting all the nutrients you need. I'm going to have to give you supplements because there's no way you can get B12, adequate amounts of zinc, omega-3s without it. Right? But we titrate those to your labs and ensuring you're getting the right dosages. If someone comes to me and says they want to be on the carnivore diet, I'm like, well, your gut microbiome's not going to like that. So we're going to have to introduce more plant-based foods. But if you wanted to keep animal protein, meat in your diet, we will make it work within the guidelines to get you to target.
And do you have like a rough guideline, like how much animal beef like should be eaten in a meal or in a day?
I mean, red meat in general is hard because it's high in saturated fat, but it's also high in TMAO. And TMAO is a byproduct of foods that are rich in carnitine that can lead to arterial stiffness and more plaque progression as well. So again, it depends. If someone's eating meat 3 times a day, am I going to tell them, hey, let's only eat it once a month? That's not going to really work. It's about bringing down the portions, but what are you pairing it with so that we can get you to targets and get you to the right goals?
one of the things that was clear to me in kind of interviews that I saw, and especially in this interview, is your approach takes a lot into account. Like it'd be very easy to like, you need to eat this, and here it is, and go do it, and that like you're taking the human aspect of it. Like you've said at least once, probably multiple times, I got to meet you where you are, and then walk you off the cliff if that's the right description or whatever. Right? Is that kind of innate in you, or you had to kind of adjust your approach so that you're getting better results?
I've always been like that because food is complex. You can't just give someone a sheet and say, follow this. Can you do that for the rest of your life? Can you do that when you're traveling, when you're at a restaurant? Can you do that and enjoy yourself? No. And this is quality of life. We want to live a long, healthy life that's with good quality, with the people we love. And that requires a lot of social gatherings that contain food, and we need to understand how to navigate that all. So I've always taken a personalized approach because every single person who walks into my office is different. They have different cultures, they have different food preferences, they have different food allergies, they have different labs. So you have to personalize science. It's the only way that works. And I've seen such success that no research study has really put into practice because it's just not something that people are doing. Literally sometimes fall off my chair when my clients call me and they go, Michelle, you're not going to believe this, because the power of science-based nutrition is huge, but it comes with personalization. That's the honest truth, because it works. It works long term. I mean, I had a client who had his third heart attack. He was 46. He came to see me because he's like, Michelle, they told me to lose weight. So I went on the paleo diet. I went on this diet. And I keep getting heart attacks. Like, what am I doing wrong? At the third heart attack, he also said, the doctor wants to put another stent in me, but he says I'm too inflamed and I got to come back in 3 months. So we worked closely together to create a personalized plan for him. He went back for an angiogram to get another stent placed, and the doctor's like, I don't need to give you a stent anymore. And I'm like, what? That can happen? Because you don't hear, no study is looking at that. But it takes a lot out of coaching and meeting someone and listening. I listen a lot to my clients. Where are they? What is realistic? And this person actually, it's his his heart attack happened his last heart attack happened 4 years ago. And every heart attack would happen every 8 to 9 months. There'd be another heart attack before he came to see me. And I say this because it brings me so much joy to see that someone's sustaining a lifestyle. They're enjoying it. I mean, he goes tailgating. He went to Argentina. He's gone everywhere traveling. He goes and he's a big CEO. And he's like, I take out my team and I order this. He is monitoring his labs so every 3 months, and they don't move. I'm like, are you sure it's not the same? Like literally, his numbers do not move.
These are the same numbers. Are you cheating?
He's like, no, these are what it is. But I say this because, you can't get that in a randomized double-blind control. We're people. We need to personalize it. And each person's journey is going to look a little different. And that's okay. And I think in order for us to really help individuals, it needs to be personalized. And we need to teach people the why. Because without the why, it doesn't matter. You can do something for a week or two with no why. But when the why is there, they're like, all right, did I get this? Because I need nitric oxide to work, and I need this, and I need this, and I need this. And okay, I have this. It's like their mind just works differently because they're trained to understand how these foods have such a therapeutic and beneficial effect on their heart health.
So Michelle, early on, you made this decision to address things up front, right, instead of on the backside of things with a medical degree. What changes do we need to make in our medical system, whether it's at the education level, whether it's actually at the practice level? Maybe you need to be with somebody like you needs to be with every physician as they go through what are the changes that you think we need to make? Because we're throwing these Band-Aids is just not the right approach.
Well, I think it also comes down to the time, right? When you go to a physician's doctor these days, they have a quota that they need to fill for insurance policies. It's 5 minutes. I can't explain heart disease in 5 minutes to you. Okay. Neither can doctors. So if I told you that doctors have told patients to go Google it, worst thing you could tell someone. If I've told you patients said, oh, your calcium score is high, just take a statin. And how many times people have left not taking a statin because they Google it and the statin says it's going to cause all these problems. And so they have no idea what it even means. No one even knows. People read calcium score and they go, oh, I should stop eating calcium in my diet, which is the opposite of actually what you should be doing. But it's just you don't have a medical degree, so you just don't know. A lot of times, we put, and just maybe in the past, we put doctors on a pedestal, right? Like my parents have always been like, oh, be a doctor, be a doctor, be a doctor. And so you put them on these pedestals, and they mean well, but they just don't have the time to explain everything to you. And without the explanation, you don't understand what that means practice wise. Cardiologists, internists don't really have any education on nutrition. I have many doctors who are my clients and they go, Michelle, I had no idea. I just took a statin for the last 15 years and then I had a heart attack and I didn't know, because they're not educated on that. They're really good. I work with brilliant cardiologists and internists. They're brilliant at what they do, but it's medication management and it's surgery and all those things. And I think a big part of it is realizing that you need to be your own advocate for yourself. You need to be asking for certain numbers. You need to be asking for a copy of your blood tests, right? Most people don't know their average blood sugar. Most people have no idea what their cholesterol levels are. They'll go, oh, the doctor said I was fine. Well, the doctor said you were fine because you're not at target levels to medicate you, but you're still brewing plaque underneath the surface because we're now in prevention mode. So you have to be aware. I think it's going to take a while there's many doctors who are being more preventative. We're seeing that, but it takes a lot of time and personalization and really looking at everything in a risk assessment, but you're also battling insurance, right? A lot of times the doctor has to say, well, if I can't order that lab because insurance won't cover it. Right. And so, because insurance is still on a treatment model basis. So we have work to do, but I think it comes down, in order to move the needle, you need to take care of your own health. Don't wait until the doctor says, oh, blood pressure is high, here's a pill. No, blood pressure has been way too high for too long at that point. You need to know, what is it, my targets? What are my numbers? And you have a lot of room to improve them, science-based nutrition early, but you have to know that they're high or that they need attention in order for you to do that. And that needs to come on the patient needs to take that on themselves to advocate for it and to become more knowledgeable of it.
Yeah, I think with the standard American diet, it would be pretty fair to say that most people's numbers aren't ideal, and that there need to be adjustments in general.
Yeah.
Yeah. All right. This is great. Anything else? I feel like we covered all the stuff that I was looking for, although I'd love to dig in more. Don't have time. Just want to make sure I've got my wrap-up questions, but is there anything you kind of feel maybe we missed as it refers as it pertains to cardiovascular health?
All I will say is you're never too early and you're never too late to take care of your heart health. I think a lot of times, I had a 93-year-old woman, so sweet. I'm like, why is she coming into my one-on-one and my group programs? This is the oldest woman I've ever had in my. She reversed her AFib. She improved all of her lab values at the age of 93. I was like, I desire to be like you. Keep trying to improve at the age of 93. She's like, Michelle, I keep waking up from AFib and the doctor tells me I should just sleep it off. How can I sleep off this uncomfortable feeling? And so we worked on inflammation. We worked on adding in nutrients into her diet. And I bring this up because I think a lot of people are like, oh, I'm old. It's too late. I already have plaque in my arteries. I'm not doing anything about it. You can do anything at any time. And that time should start now. Just small, simple steps. And then some people, in the 20s, 30s wants to sees this person with a six pack and, oh, that guy looks good. I'm going to do what he does and not realize this is the opportune time for you to really take care of your health, to set yourself up for your 30s, 40s, 50s. It happens decades before. So no matter where you are, no matter your age, no matter what you look like, heart disease does not discriminate between underweight, overweight. It doesn't matter what your physical appearance looks like. Know your numbers, target them to optimal. optimal option, like optimal targets, and make sure that you're continuously monitoring them. We need to make sure we're metric driven, but we also need to understand, where you are and how to personalize this for the long term. So I just wanted to put that out there.
Yeah.
No, it doesn't matter your age, doesn't matter what you look like. You can do something today to protect your heart.
I need to connect you with Dr. Nash so you can be out there saying that everything is age appropriate, including getting your heart health right.
Yeah.
All right. So here are our wrap up questions. Michelle, do you have a target age that you want to live to?
I never really thought about this, but I'm just going to spew a number, 96.
96. I like it. And how long do you think humans can live?
A good quality life with everything kind of going well, I would say 100, 105.
We'll go with 105. What are 2 to 3 protocols, habits, mindsets, let's call them shortcuts because everybody likes shortcuts, for longevity and a long health span that you would share?
Habits that you can do right away. I would say one neglected one is hydration. As we get older, our thirst mechanism decreases and we really need it. I always will bring it back to heart health, so I'm going to try making this short. But if you are dehydrated, your blood is stickier, it is thicker, and it is more susceptible to plaque buildup. So make sure you're hydrated. That's one. I will say focus on what you're adding to the diet versus removing from the diet. And then the third will be there's no quick fix. As we age, especially as women's hormonal changes happen, the body fat distribution can change. And a lot of times people go on caloric deprivation diets, which we show can actually worsen menopause symptoms and worsen heart disease. So make sure you're focusing on nutrient adequacy and long-term sustainability. It's not about quick fixes. It's about the simple things you do each day that will help you achieve your goals and live a long, healthy life.
Yeah, we probably didn't talk about something that I would imagine is very important, which is like movement and exercise. Like that's another key. Maybe for another episode. What are 1 to 2 things people get absolutely wrong regarding longevity and a long health span?
I think they think that it happens overnight. And they don't realize that it takes years to develop a health span, and we need to start as early as possible to set us up for functional aging and motility as we get older, right? A lot of people are like, oh, I heard I need to increase muscle mass. I'm going to eat a lot of protein. And they're like, I'm aging. So they just go,
hey,
oh.
are you?
They just go all in and realize like, oh, wow, I had double the amount of protein that I had yesterday. And it's too taxing on the body. If you are really focusing on, in my 70s and my 80s, I want to pick up those groceries well. It's about the functional aging and creating mechanical load in a way that's not going to cause injury, but it's going to help you. So that takes slow and steady progress and small changes versus drastic changes to get there.
Very good. How can people contact you, Michelle?
You can visit me on my website, entirelynourished.com. I have a free newsletter with heart health tips. I also have an Instagram page where I share a bunch of things as well. I'm also on LinkedIn, but check me out on my website, entirelynourished.com, for where all of those things are.
And what's your IG handle?
heart.health.nutritionist.
heart.health.nutritionist. Okay, excellent. And what in the near future are you excited about?
Near future, I'm going to a lipid conference in the end of May in Miami, and I'm excited to connect with some fellow lipidologist geeks because that's my jam.
There's a part of me that's like, that sounds so boring, and I know it's going to be so exciting for you, but and I'm in the middle of like assessing my lipids, and so that should be really interesting. No, we all have our little geeky corners, so that's pretty awesome. All right, you can find her on her website, entirelynourished.com. She has a newsletter there, so make sure you go there and subscribe and get on this newsletter. And it doesn't matter how old you are, or young you are, go there. heart.health.nutritionist, right, for your IG. Check out our website. Michelle, thank you so much for joining us today.
Thank you for having me.
I hope you enjoyed this episode of the Live Beyond the Norms podcast. Make sure to subscribe and follow. Also, make sure not to be that guy, the guy sharing this podcast with people who are not interested in living beyond the norms. If you would like to learn more about the ESS60 molecule, the molecule responsible for the single longest longevity experimental result on mammals in history, a full 90% extension of life, visit myvitalc.com. That's myvitalc as in carbon.com.